I'll just quickly go the history of bladder cancer treatment. So in somewhere in late 70s, response rates of anywhere between 10% to 30%, and then the attempts were being made to come up with combination chemotherapy, and the MVAC was developed by Memorial Sloan Kettering somewhere in '83 or something. It showed a good response rate that led to a intergroup trial. I must tell you, in bladder cancer, most of the trials have had some problems because of accrual. The accrual of patients in these trials have been very difficult, and I actually am very delighted that Tata can do it because they have enough patients. All other trials you have to take with a pinch of salt some of their results. So anyway, so therefore the need for meta-analysis and those issues were there. So anyway, so the MVAC came as the next treatment, which was compared with cisplatin, and it showed that there was a definite improvement in overall survival and disease-free survival. I also must tell you, there has not been much change in the overall survival with all those new chemotherapy drugs which have come from 12 months to 15 months maybe. So then it was also proven that MVAC, when compared with cystectomy alone, improved the overall survival from here from 77 months, from 46 months to 77 months. But the problem was, like Dr. Naresh said, the problem was the toxicity. MVAC was causing significant toxicity of leukopenia and neutropenia. People will interrupt the treatment. There will be interruption. There will be discontinuation with this MVAC. So then came the. They were making attempts to improve that, and then came the another international trial which compared gemcitabine and cisplatin with MVAC, and it shows equivalent overall survival. So gemcitabine cisplatin became the chemotherapy drug to be used, and MVAC got a little backstage. It was not till recently then dose-dense MVAC came, and it showed the comparable survival or even better survival in metastatic urothelial cancer. So dose-dense MVAC became the standard of care. Now we're gonna. So with this background, I have a patient which we will sort of. So that we have a 71-year-old male, never smoker, with hypertension, diabetes, and chronic neuropathy with increased frequency of urination and hematuria over the last 2 months. He is obese, BMI of 33, ECOG performance status is 0, his creatinine clearance is 54, CT scan of chest abdomen pelvis shows a right lateral bladder wall lesion, and MRI confirms that, and he has a surgery, and the pathology shows urothelial carcinoma is CT3 and 0. Now the question is, what are our recommendations? Should we give him neoadjuvant chemotherapy with dose-dense MVAC or gemcitabine cisplatin, or should he get cisplatin at all? Or should we use carboplatin instead of cisplatin? Or should we split the dose of cisplatin like Dr. Avinash was saying? Or should we proceed to radical cystectomy? Or what do we do if patient refuses radical cystectomy? I just want to refresh, most of the oncologists know this, that cisplatin and carboplatin, though sometimes used interchangeably, they are not same. Cisplatin in earlier studies, when they both cause DNA adducts as their mode of action, but carboplatin, it was proven that carboplatin required much higher drug concentration and much longer incubation time to cause a plasmid DNA damage. So this was, and then they both require, they are both renally excreted, but the difference is uh, carboplatinum, cisplatinum is secreted as well as excreted, whereas carboplatinum is straight away secreted, and it is very directly related to GFR. If we don't dose it correctly according to GFR, it will tend to accumulate and will cause toxicity that way. Otherwise, it is much less toxic. It's hardly renally toxic if given at right dosages, and it doesn't cause much nausea, vomiting either. So it doesn't cause much of neurotoxicity. So carboplatinum, one thing is it's not synonymous or it's not similar to cisplatin. So in our patient, considering carboplatinum, we have to take these things into account. The other thing is there have been a lot of trials being done to compare carboplatinum with cisplatin. Most of these trials, they were small trials. They didn't accrue many patients, but these 4 trials, if you can see, in none of those trials carboplatinum was better than cisplatin, even though they were mostly phase 2. So then came the ERTC trial. This was published in JCO in 2011. So what ERTC did was they took patients who were ineligible for cisplatin and they allocated them to gemcitabine, gemcitabine and carboplatinum versus carboplatinum and methotrexate vinblastine. So their comparison groups are somewhat. There was no adriamycin in the comparator arm. So they did this trial, and then they showed that there was no difference between methotrexate carboplatinum and vinblastine and gemcitabine carboplatinum. So this was taken as by many as that one methotrexate based regimen and the other carboplatinum based regimen, they are equivalent. So carboplatinum got to get used very frequently in patients. Now, the Dr. Avinash Pandey also showed that eligibility for cisplatin, who are eligible, there has been no randomized or proper trial for this. Most of these assessments have been done on the basis of surveys. In 1997, they did the first survey. EORTC did the first survey of 40 GU oncologists, and they asked them under which creatinine clearance you will not give cisplatin. They just said 60, and some of them said that the 2 things which came up early on in EORTC was creatinine clearance less than 60, performance status 2 or more, they will not give cisplatin. Then there was a working group which was put their findings. They also did the same thing. They interviewed 120 academic institutions and asked the GU oncologists there, hey, what would you do? They said creatinine clearance less than 60, approval of newer coming drugs. So when they call it cisplatin-ineligible, they use these criteria. And then there was another group which looked at these criteria. So when talking about performance status in this, so the 2 most important factors which have been seen is, one is the performance status. In this trial where they compared performance status with the overall survival, performance status had a huge impact on the survival. So going back to our patient. There is no data to show the benefit of carboplatin in neoadjuvant setting. So it is not recommended by NCCN either. So carboplatin is out. Should we use cisplatin split dose like Dr. Avinash was saying? That is also
borderline GFR.
right. The some physicians, they say the GFR is between 50 and 60. We can use a split dose cisplatin, but I do not know whether there is a strong evidence to that. Uh, so so generally standard is to, if it is less than 60, no, you know. Uh, and can we proceed with the radical cystectomy since we can't do any of those things? The radical cystectomy would be one.
So I think in this patient, we should actually sit with the urologist, the radiation oncologist, as well as the patient,
Right.
do a multidisciplinary discussion. Radical cystectomy can be an option, and bladder preservation with that modality therapy using concurrent GEM can also be an option, and as the depending on the patient's preference.
Right. No, but same this thing comes up when patients refuses this radical cystectomy.
Yes. So
that's what we'll have to do.
So
before he gets to refuse, we should offer him both the treatments, and if he decides to preserve, then
of course, yes.
Yes.
When we're going to do radical cystectomy, it has to be good.
It's a major surgery. He's already 71. He has multiple comorbs.
Right. So that is also a problem.
Yes.
So that's why he's refusing radical cystectomy. Then what do we do? So then I think what we can do is we can use the neoadjuvant chemotherapy and we can probably try carboplatin or split doses platinum and see the response. And then after the response, we can decide whether he needs radiotherapy or radiochemotherapy. So that should be the So there's another patient. He is 68 years old, male, diabetes type 2, hemoglobin A1C of 6.9, creatinine clearance of 44.2, grade 1 diabetic peripheral neuropathy manifested mostly in the feet, BMI of 32, 26 pack area, just smoking, 2 weeks of intermittent hematuria, CT urogram, mass in the urinary bladder, and a large right iliac lymph node. And cystoscopy confirms muscle invasive urothelial carcinoma. His staging CT shows bilateral lung nodules with enlarged mediastinal lymph nodes. So biopsy confirms that metastatic disease. Now he is referred to medical oncology for systemic therapy. So what are the options here? Again, do we have now he is cisplatin ineligible. He is not eligible for cisplatin. So can we use carboplatin in his condition? Yes, we can. So this is a metastatic. Now we are treating metastatic disease, and we can definitely use carboplatin in his situation. How about other combinations? People have used cisplatin with Taxol, taxanes, gemcitabine with Taxol. So can we use other combinations? None of the combinations has been proven to provide as good results as cisplatin and gemcitabine or carboplatin and gemcitabine. So those are the best combination. Now there's been a recent talk of using checkpoint inhibitors alone in the treatment of cisplatin ineligible metastatic urothelial carcinoma of bladder. So one of them had used pembrolizumab and other one was atezolizumab. And so the interesting thing is when pembrolizumab initially was investigated in the keynote 052, where they were trying to look at the responses and toxicity, the response rates were 24% or so, but the responses are more so in patients who had a CPS score of more than 10, combined score of looking at the expression of a receptor in the tissue. So there is a scoring system, and according to that scoring system, if they had 10% or more of that score, they got a better response. But 10% had severe grade 4 toxicity, grade 3-4 toxicity as well. And when they did this as a randomized trial in Keynote 361, when they compared pembrolizumab plus chemo with chemo alone, there was no difference in overall survival or disease-free survival. But when they compared pembrolizumab alone with chemo alone, there was no difference in overall survival, and there was a slightly better with the patients who had a combined score of 10 or more. So the similar kind of a investigative trial was done with atezolizumab. Again, this trial did not show any solid difference between the chemo and immune checkpoint inhibitor versus chemo alone versus immune checkpoint inhibitor by itself. So atezolizumab was also not very effective, and in fact, they said that if you look at the overall survivals, here it says 16 months, and then it says in the atezolizumab alone it was 13.4 months. So the point I'm making is we had seen that the overall survivals in metastatic disease, even with gemcitabine, cisplatin or MVAC, they were about to the tune of about 15 months. We have not really made any significant difference with these checkpoint inhibitors. Now, then, so if you look at the atezolizumab, if you look at the median survival, it will fall around 12-15 months. The only thing which it was observed in atezolizumab was that patients who had high tumor burden had a better survival as compared to those who did not. So they divided these mutational tumor burden into various quartiles, and then they found that the patients who had higher tumor mutational burden had a better survival. Now, there was a recent trial of using enfortumab vedotin. This is an antibody drug conjugate. So what is seen is that patients with bladder cancer, they have overexpression of a cell addition molecule called nectin-4. So they have developed an antibody against nectin-4, and then they have attached with a linker, and they have attached a chemotherapy to it. The orange dots represent monomethyl auristatin, which is a sort of a chemotherapy. So what happens is these tumor cells have the nectin-4 antigen. The antibody binds to it. The antibody gets internalized, and then it releases the monomethyl auristatin. And this is a cytotoxic to microtubules in the cancer cells. Okay, so what happens is, this particular trial had a beautiful response. The responses were very quick. They were 73% people responded very quickly, and it was a small study. It was phase 1 study. And then if you look at the interesting part is this trial, in some of these patients are alive 24 months after. So this is the first trial which showed a really prolonged survival after treatment with pembrolizumab plus enfortumab. So, however, I must say that these are the trials. This drug, short-named as EV, there are a lot of trials going on with the antibody drug conjugate. So this drug is on first line in phase 3 trials also, so the results are awaited. But the problem with this drug is, again, it causes neuropathy. It causes very significant neuropathy, and in patients who are metastatic disease with poor, if they have if their performance status is not up to the mark, these drugs will not be able to be given to those patients. So peripheral neuropathy is a very significant complication of this drug. So even though the survival looks very good, but we have to see what the cost of the patient is. So Um, so the only thing when we are looking at the response, the only thing which I wanted to add was that we need to look at the pathological response, and then it was shown in that atezolizumab, dosed in neo MBAC, that if they had a pathological response, they had a better disease-free survival. Now, what are we going to do in future? Basically, we are looking for a role of tumor mutational burden, as we saw in this slide. Then the other thing which they found was that the mutation in ERCC2 and HER2 they are more responsive to cisplatin. And the other things we need to do is we need to develop less toxic regimen and possibly develop alternatives to platinum agents, which are an agent which are equally or more effective. So with this, I'll conclude. Thank you.